Hello students, hope your exam was fine. At least as far as dermatology was concerned, I think they were very straightforward questions. So today I'll be discussing these recall questions. So we all know that recall questions are the questions which you recall for us. So they may not be exactly in the same language, or there may be some differences in the options. So but we have put in whatever we got from you guys, and I'll be discussing briefly about that question, so that even if it was not exactly the same question, you would know what the answer was based on what you think is the correct question. So I had one question that a truck driver came with complaint of painless genital ulcer after unsafe intercourse, and motility of the organism can be best checked by which type of microscope. So now here they are giving us a few informations, like there is a painless ulcer, genital ulcer, which has come after a unsafe intercourse. So I am dealing with the STI and I am dealing with a painless ulcer. Now when if you remember, we had discussed that there were 5 main causes of genital ulcer: chancroid, which was painful; herpes, again painful; LGV, which hardly presents with an ulcer; donovanosis, and syphilis. Now donovanosis is usually not considered, it is a painless, but there is a lot of beefy granulation tissue. So in the question they would mention something apart from painless genital ulcer. So when we are talking about painless genital ulcer, this is most likely, this is syphilis that they are talking about, and this genital ulcer is nothing but chancre, a primary chancre. Now we all know syphilis is caused by Treponema pallidum, which is an organism which cannot be stained. So what do we do for that? We do a dark ground microscopy. So here the answer would be dark ground microscopy. Now even if we think that okay, donovanosis is painless, and that might also be an option, there also we do not do a microscopy. We all read that we do a GMSA stain and I see a safety pin appearance over there. Okay, and also donovanosis ulcer can sometimes be painless depending on how the presentation is. So here there is no confusion. The answer is dark ground microscopy, because here we are talking about primary chancre, which is caused by Treponema pallidum. So here very clear cut, very straightforward question talking about dark ground microscopy. So here this is from your eGurukul notes. I had discussed it in our classes that how does a primary syphilis present as. It presents as painless single ulcer, and usually since it's a STI, it would appear after a intercourse which is unsafe. And what do we do? How do we identify the organism? We do a dark ground microscopy, where we see it as slender, thin, wavy organisms. And where do we take the sample from? I told you we take the sample from condyloma lata, mucus patches, chancre, and lymph node. Here in history, in the question, they are referring to chancre. So what test you would do? You would do a dark ground microscopy. Next, there was another question on STD which mentioned a migraine laborer. So whenever they are talking about an STD, they will give you a scenario where the person is not staying in his home, a truck driver, a migraine laborer, or something like that, where the chances of having extramarital contact or unsafe sexual contact is higher. So a migrant laborer came with complaints of urethral discharge after 1 week of unprotected sexual intercourse. So they are giving you an incubation period which is less than 1 week. So what is the causative organisms? Now here the only confusion could be whether it is a gonococcal urethritis or a non-gonococcal urethritis. So this is definitely a case of urethritis. They are giving you in the image also that there is a urethral discharge which is coming out. Now we have to identify whether it is gonococcal or non-gonococcal urethritis. Now if you remember in our classes, I had told you gonococcal urethritis presents with profuse whitish to yellowish discharge associated with some urinary complaints. Now there were few students who had also told me that here there was history of burning micturition. So they had given some history of constitutional symptoms as well. So there was history of constitutional symptoms. If I look at the image, it's a very purulent looking discharge. It's a whitish looking discharge, and it's a profuse discharge which is coming out of the urethral meatus. So here we are talking about gonococcal urethritis. With NGU, the discharge is more scanty and it is more watery, and usually we do not see a lot of constitutional symptoms here. So, since we are dealing with gonococcal urethritis, what would be the causative organisms? It would be Neisseria gonorrhea. Now, there is a possibility that the image that I have put in was not the exact image that you had got. So, in case what was there in the image was a more scanty looking watery discharge was there, then what would be my answer? Then my answer would be ureaplasma ureolyticum. Why? Because non-gonococcal urethritis is not just caused by chlamydia. It is also caused by ureaplasma, mycoplasma, and we should be knowing about that. So, but I think that they would have asked you about gonococcal urethritis only because they have mentioned an incubation period of less than 1 week. Then some students said that there were constitutional symptoms, and with you they'll be more direct. They would have given chlamydia as an option if they were asking about non-gonococcal urethritis. So, since they have not given that as an option, I think the answer would be Neisseria gonorrhea, and this would have been the image. Now, if you remember in our notes, we had seen this image. So, see, this is something similar. If you got something like this, so this is gonorrhea, there is constitutional symptoms, there is burning micturition, and there is a thick, purulent, copious discharge. Whereas non-gonococcal urethritis, which is caused by chlamydia, mycoplasma, and ureaplasma, which was there in the option, the discharge would be something like this: very, very watery discharge, very scanty discharge, which I don't think is there because most of you told me that it was a whitish, yellowish discharge which was there. Okay, so in case the question was something different, this is there in the notes. You could have answered it pretty well. Now, next question was on pemphigus. Again, a very straightforward question. A 30-year-old female came with flaccid bulla on her skin, which was easy to rupture. Flaccid bulla is always easy to rupture. Biopsy revealed suprabasal split. So, what is the diagnosis? So, now I have a flaccid bulla, so I know I am dealing with pemphigus group of disorders or intraepidermal disorders. Okay. Now, here the options were vegetans, vulgaris, and foliaceous. Now, what is vegetans a variant of? Vegetans is a variant of pemphigus foliaceous, whereas both pemphigus has two main types, vulgaris and foliaceous. So, I had told you how do you differentiate between the two. In vulgaris, I have flaccid bulla, which again will rupture easily, and here the split is suprabasal. Whereas in foliaceous, we hardly see any bulla. What do we see predominantly? We see crusted erosions. And even if you see a bulla and do a biopsy, where is the split? The split is subcorneal in nature. Okay, so here the only confusion would have been between these two. So, obviously, EM is nowhere in the picture between vegetans. Vegetans, you know, is a variant of foliaceous. So, like foliaceous, you see a subcorneal split and you see more of crusted erosions. In vegetans, you see more of hyperkeratotic lesions, vegetating lesions on the axilla, on the groins. Okay, so that is how you differentiate clinically. And if we do a biopsy, I see a suprabasal split in pemphigus vulgaris. So, here the answer would be pemphigus vulgaris. Again, a very, very clear-cut question. So, this is from our eGurukul notes. So, in pemphigus vulgaris, I had talked about that the target antigen is desmosome, and so the split is suprabasal in the stratum spinosum. And in the clinical features, we had talked in detail that there are flaccid bulla which rupture easily. So, flaccid bulla are seen which rupture easily and which shows a suprabasal split. The next question was on leprosy. A patient who is on MBMDT, so patient on treatment, presented with inflammation or with increased redness or swelling over pre-existing lesions and nerve involvement. So, what will be your treatment approach? So, here what are they referring to? They are referring to a type 1 leprosy reaction. Now, type 1 reaction, if you remember, happens in patients who are towards the upper end of the spectrum or maybe lower end, and you start them on MBMDT and they develop this type 1 reaction. If you remember, type 1 reaction was the type of type 4 hypersensitivity reaction. Now what happens in this? In this, the existing lesions, they become more inflamed, they become more swollen, they become more red. Patient may have constitutional symptoms. So here you should know what are they talking about. And okay, so to give you a hint, even if you're not able to know that whether they're talking about type 1 or type 2 reaction, the good part is that from the options, if you look at the options, the answer would remain the same. However, if they had talked about type 2 reaction, they would have said crops of new lesions happening in a patient of leprosy. They would not mention MBMDT, because when you start MBMDT and a patient develops a reaction, it's called an upgrading reaction. This is usually a type 1 reaction. But then, as I was saying, even if it was a type 2 reaction, according to my options, the answer would not change. So any kind of reaction a leprosy patient develops, you never stop ALT. We had talked about this. So obviously these two are not in the consideration. Now coming to the next two option, you obviously continue with ALT or MBMTT, and would you start steroids or would you give thalidomide? Now, as a drug of choice for both types of reaction, it is corticosteroids. So thalidomide is used for type 2 reaction, but that is not my first choice of drug. So now look at the notes that we had already studied. So there are two type of reaction, type 1 and type 2. Type 1 is usually which occurs after starting treatment, 2 weeks to 6 months of starting treatment, and the existing lesions, they become erythematous, tender and edematous, and there is nerve involvement which is there. And there is nerve involvement. And how do we treat it? We continue MDT. In mild cases, we give NSAIDs, and in severe cases, steroids is my drug of choice. So here the option would be continue MDT and start the patient on steroids. Whereas in type 2 reaction, I already said, seen in lower end, and usually there is no change in existing lesions. You have crops of lesions, and what do? We again continue MD-MTT, give NSAIDs, and again my steroids would be my first choice of drugs. Okay, so then there was this question. There were two questions, in fact, what you guys told me, that there were two questions on niacin or pellagra as they were. So there was one question which mentioned about a female or someone who was on prolonged maize diet and developed some reaction or some symptoms. So a patient who's on prolonged maize diet is usually deficient in niacin. Okay, so that can lead to this. And then there was this question in which they had shown what is called as Castle's neck. So they have shown Castle's necklace. The sign I had told you that Castle's necklace is a sign of pellagra, and pellagra is associated with 3 Ds: diarrhea, dementia and dermatitis. Okay, so now there was a lot of different things. So this was given, that was given, but there one thing was sure, that in the options you were asked about what are the other associated features you would see. So see, now they give you more of clinical questions. It's not a direct question that where do you see Castle's necklace. So you should know that Castle's necklace is seen in pellagra. What is pellagra? You should remember 3 Ds: diarrhea, dementia and dermatitis. So there is in the option they were asking you about associated features. So history of diarrhea or dementia would be my correct answer. Even the question, if it was same or different, we are not sure, but in case there was another question probably in which they had mentioned about patient on prolonged maize diet develops some symptoms, what other associated features would you see, or what is the deficiency? Anything can come. So here, so we have talked about this, that vitamin B or nicotinic acid, B3 or nicotinic acid niacin deficiency gives rise to pellagra, which is diarrhea, dermatitis, dementia and eventually death, seen in people on staple diet of maize, which was there in one of the questions. And what do you see? You see this appearance, which is called as Castle's neck appearance in chronic cases. There were other signs associated with it like Caraway sign, Pellegrin's nose. So, but Castle's neck is involvement of neck and anterior chest with chronic erythematous plaque seen in cases of niacin deficiency or pellagra. The next question was something like this. A girl child was presented with rough lesions over her elbows and knees. probably on the extensor surface, and had problem of night vision. So night vision and developing these lesions. So this is vitamin A deficiency. What does vitamin A deficiency leads to in skin? It leads to phrenoderma. This is not keratosis pilaris, though clinically you might get confused, but history of decreased night vision and having this lesions on the extensor surface, which are rough hyperkeratotic lesion, is phrenoderma. Now remember, I had told you phrenoderma is basically a deficiency of essential fatty acid now, but initially people used to think that it is only due to vitamin A deficiency, so usually they are clubbed together. So this is what we studied in vitamin A deficiency, that there is night blindness, there is steatosis or dryness, and there is phrenoderma or toad skin, which is due to mixed deficiency of A, B, C, D, E, fatty acids and all of them. And how does a patient present with? Follicular hyperkeratotic group papules, which horny spine, which are present on elbows, knees, posterolateral aspect of thighs and arms. And how do you treat? You give vitamin A. So one thing which we had discussed so many times, a child presents with boggy swelling in the scalp. I had told you, anything which is boggy swelling, don't think just mark chirion as the answer. There is nothing else in dermatology which you would be given which would present with boggy swelling. So there was a boggy swelling. So this is chirion. So what was the, then there was something like pet animals were there in the home. So this is relevant because I had told you that inflammatory type of tinea capitis happens because of zoophilic infections, infections which are transmitted from animals to humans. Okay, that is why my body mounts a lot of inflammatory response and leads to inflammatory form of tinea capitis. Now there are two inflammatory tinea capitis we know of, chirion and favus. The image is very suggestive of chirion, boggy swelling being present. So there is no doubt in this question that it is a chirion. Okay, now again, in our topic on dermatophytosis, we discussed that there are three species, and zoophilic species is which is trans animal to human, and thus it is more inflammatory. And chirion, we have discussed so many times that it is boggy, indurated swelling which is present on the scalp, and it has associated loss of hair, pustules, crusting and everything. And so it is majorly caused by varicosum and ferruginum. And when you do a KOH or culture, it is negative because my body mounts so much of inflammatory response that the fungal hyphae are actually killed. Okay. Then there was some question on hair perforation test which I could not get clearly, but they had probably asked that hair perforation test is used in, or they had given you a patient of tinea capitis or circular patches of loss of hair. How will you identify the organism? And they must have told you hair perforation test is positive. So this you must have studied in microbiology, but I'll quickly recall it with you. What is a hair perforation test? It is used to differentiate trichophyton mentagrophytes and its variants. So it's used mainly for trichophyton mentagrophytes. What do? You take the hair, you cut into short pieces and you put it in a sterile distilled water. So now when you put here the water and you inoculate it with the test fungus, you see these hair which have, and you examine it microscopically by adding lactophenol blue. Now what happens? The isolates of T. mentagrophytes, they produce localized areas of pitting and marked erosions. So there is localized areas of pitting and marked erosions. So you do not need to remember the whole test in detail, but hair perforation test is usually positive for trichophyton mentagrophytes. And if you remember, trichophyton mentagrophytes causes chirion. Okay, so now in this exam probably they had given you same topic, 2 questions. So I got 2 questions on niacin and I have got 2 questions on tinea capitis, but this was more of microbiological question, but they are correlating it, so it's an integrated kind of a question. So then this question, I think a lot of you have had a confusion, and I think what it was, you were given an image of a phelon or an abscess of the finger, and then there was this linear lesion which was there on the forearm. So this linear lesion which they had given you, a lot of you told me that probably there was dermatographism or something, but I think it is what they're showing is lymphangitis. Now see, if there is a phelon or abscess of the little finger, that infection can spread along the lymphatic glands and can lead to a linear lymphangitis kind of a lesion. And so what will you give? You have to treat the infection. We have talked about it. Whenever there is an abscess, we suspect gram positive organism to be the cause, and there can be associated gram negative. So my best choice here would be amoxiclav. I will give amoxiclav to the patient, not Amica, not Norflox, not metronidazole. Any kind of abscess, my treatment of choice is amoxicillin, or I can also use cephalosporin. In the options, they have not given you cephalosporin, so my treatment of choice would be amoxiclav. But what I want to stress here is that this linear thing was not dermatographism. This was probably lymphangitis, which can always be associated with any kind of abscess of the fingers. Okay, so then there was this question about a 23-year-old female who's a primi gravida whose school-going cousin stays in the same house and contacted varicella infection. Patient approached the medical center, testing of varicella antibody negative report. So there is a pregnant female, there is a cousin of that pregnant female who is having varicella or chicken pox. So probably they are talking about, they just said varicella infection, they probably were talking about chicken pox. So now the cousin has developed chicken pox. Now the pregnant female goes and get the antibody tested, and the antibodies are negative. So what does it mean? She is susceptible to zoster? No, it doesn't tell me anywhere. She is susceptible to chicken pox, she is immune to chicken pox, or she is immune to zoster. So here the answer would be she is susceptible to chicken pox, because the antibodies are negative. That means she has not had prior chicken pox in her lifetime, because usually chicken pox happens once. So if you do the antibodies, it should be positive. However, these antibody tests are not 100% sensitive, but based on this question, she is susceptible to chicken pox. That should be the answer. Okay, so these were the derma recall questions that you had given me, and in case there are any more that you can remember, or if you have any doubts, please ask. Thank you.